the second lesson of the day. I think when these conservative measures fail, we may need an orthopedic surgeon to reconstruct. It's my pleasure to invite Dr. Aravind Rajagopalan, who is the co-director of the High Care Wound Center, which is hosting this conference, and is a senior orthopedic surgeon with a focus on Charcot reconstruction in the diabetic foot. Over to Aravind.
Good afternoon. Professor Bal has talked the conservative way, and I am going to talk the surgical way. So, I'm sorry. Fine. And looking at for the aim, so why do we need to talk about the surgical options? We need to create an awareness among all of us about the surgical treatments available for Charcot foot. So what are the methods available? Selecting the right option always is necessary, because if you do not use the proper tool to design or reconstruct a wood, you will end up in trouble. So you need to have, say, the options for a particular patient, and then the results of the treatment. So what do we achieve? Surgical intervention is always for a stable and a plantigrade foot. The patient has a deformity, an unstable foot, with or without an ulcer. So always try to have the healing for the ulcer. We give him a stable and a plantigrade foot, that he walks with his own foot with an orthosis, preferably. Yes. So the scope of presentation. So Professor Bal has already talked about presentation of Charcot foot, pain, swelling, ulcers, deformity. Coming to the methods of management, these are the surgical methods. You have RF or open reduction internal fixation, external stabilization using AO external fixator, Elizarov ring fixator. In our center, along with Dr. Rajesh as well as Dr. Narayan Murthy, we have come a long way and finally perfected the fixation with the Elizarov method. Fine. We're talking about a case series of 21 cases, male 16, female 5. You asked me why patients come with pain. We had 2 patients coming with pain, swelling 4, patients had ulcer, patient had deformity, and no one's going to come for aesthetics. Pain is not usually a symptom in Charcot, but trauma of fall can cause pain. Deformity of the ankle due to the fracture. So patient does not have any sensation, they have neuropathy. So when they have a fall, maybe after about 2 weeks, 2 months, they come to us with a deformity. You see, that's the neglected fracture. Now this lady, a bimalleolar fracture, she just slipped and fell at home. She's about 55, she's a diabetic. She had neuropathy. She presented with pain. So you try to fix it initially along with the syndesmotic screw. She was mobilized with a cast for 3 months. And then she was again told that you'll have to have the cast for another 3 months. And she didn't listen, she started walking. So this is a neglected bimalleolar fracture, 14 years of diabetes with neuropathy. You have ulcers of the foot, midfoot. Just go through a bit of the ulcers also. The lady with neuropathy, ulcer for 2 years. She had a midfoot Charcot. The example of the ulcer is forefoot is already non-healing with the deformity of the foot, an ankle non-healing ulcer for 2 years. Fine, what are the methods? Plate osteosynthesis, AO external fixator, Elizarov ring fixator. Now this plate osteosynthesis immediate along with the syndesmotic screw. The screw was removed after 3 months. Patient was kept on immobilized cast for 3 months. After 6 months, she came back. It had collapsed. So fixing like a regular fracture may result in failure. Now the neglected patient came with pain. So he had a neglected bimalleolar fracture. Learning from the previous case, we decided to go ahead and do a tibiocalcaneal fusion. The other methods are external fixator, the AO external fixator, one plane, biplanar, triplanar. Results waited for about a year's time. Good stable plantigrade foot. The result too, this man had a midfoot Charcot and a hindfoot involvement, had neuropathy. The ring fixator was retained for about 3 months, and after that was put on a TCC, immobilized for 3 months, and then made to walk. This man had an ulcer. He had an ulcer in the lateral aspect of the foot. The foot was inverted. He was walking with it. Fine. We reconstructed his ankle, gave him a Elizarov ring fixator, retained the fixator for 2 months because he was adamant he wanted it off in spite of this one. But the ulcer healed. He had a plantigrade foot. Obese diabetic lady, 15 years of non-healing ulcer in the medial aspect of the ankle and the leg. The ankle was exposed. Only thing was she had comorbid conditions. She had a very poor cardiac status. She could not undergo a long time of surgery. So we had to put in an Elizarov ring fixator. She didn't do well because of she went in for renal failure. Fine. And I come up to this 48-year-old man, ulcer again in the medial aspect, communicating with the ankle, neuropathy, walking, non-healing ulcer. That was the condition of his. A normal X-ray showed Charcot. We stabilized his ankle, did a debridement, and in a single stage closed the wound with a skin graft. Everything healed, plantigrade foot, walking. So you're coming to the summary. You have plate osteosynthesis. Our experience in the plate osteosynthesis is not very good. AOX fix, and finally the Elizarov ring fixator. This lady, about 55-year-old lady, very bad collapsed ankle, fixed 18 months post-op. She was on the external fixator, Elizarov external fixator for about 4 months. She was on a PTB cast once the fixator was removed for about 3 months, and now she's on a cast shoe, PTB cast shoe for the last 6 months. The examination of the ankle, we found that there was a bony union. X-ray, you have certain places of bony union, but we're waiting and watching. This man, a diabetic, he's 55, he's a smoker, been having an ulcer, a deformed ankle, went in for a ring fixator, no follow-up for about 3 months, came back after 3 months, we had to do a tightening, we had to do compression at the fracture site, but he did very well. This is the 12 months follow-up. This man had a hind foot, Chaco, very bad. With a ring fixator for about 3 months and POP for about 3 months. Now he's walking with a PTB cast shoe. So in conclusion, in our series, we have found the various options discussed. Elizarov ring fixator was our choice of arthrodesis. And out of 21 cases of arthrodesis, we have got a complete stable plantigrade foot in more than about 16 cases. Now, points to be considered for is versatility, minimal tissue injury when you use the Elizarov ring fixator, against cumbersome, increased time of OT, difficulty in dressings. Our team, thank you.
Thank you very much, Dr. Aravind, for the wonderful presentation on the surgical management of the Charcot with the aim of giving a stable and a plantigrade foot on which the patient should walk. And the secret of the Chennai high care success is an external fixator. So the forum is open for the audience if they have any questions, something to share with Dr. Aravind.
Sir, I have one question. Knowing that the patient has got Charcots already, and the patient had fracture in your first case, why not go for a primary arthrodesis?
Possible. That was the first few cases of ours. So, looking at, as a trauma surgeon, looking at a fracture, we normally go and try to fix it, a bimalleolar fracture. Patient didn't tell us that patient was a diabetic. That was a problem. The sugars were somewhere around 160, so we didn't want to take a risk. So post-operatively, after about 15 days, once we asked, because the patient was on insurance, so they didn't declare that they were a diabetic. So they said no previous history. So that's why we burnt our hands. We said, no, we get everything done and then go ahead. So that was the first few cases where we did a internal fixation for a fracture without realizing the patient had Charcot. That was the thing.
And one more question, sir. Elizarov, no doubt it is the best option, but how do you achieve compression for attaining arthrodesis? Because in foot, we are applying it in multiple planes. So how do you achieve compression at the joint surface in order to achieve arthrodesis? Do you have any tricks?
Yeah.
Or,
yeah, of our series, we have done the most where hardly any talus remaining. So some amount of calcaneum is remaining. So the lower end of the tibia is trimmed, and whatever bone, preferably if it's an osteomyelitis of the talus, we remove the talus off. It's no use retaining the talus and trying to get a bony fixation. So if the talus is there or the calcaneum is gone, we try to basically do a tibio-talar or tibio-calcaneal fusion. And that we try to attain compression on day 0. We try to fix it on day 0 and then try to do a compression. If on the 8th day or the 10th day there is some amount of opening up of this one, we try to compress. We give them compressions. At that point, we give compression rings so that increases the amount of compression to a bone-to-bone.
no, sir. Being multiplanar, I am asking, sir.
Multiplanar,
it is easier to achieve
that's what I'm
compression
saying.
If you are applying the ring in tibia.
In our scenario,
But in multiplanar application of rings, it is difficult, isn't it? I feel it is difficult, I don't know. Please clarify that.
In
For
the-
achieving compression.
Yes, in achieving compression, basically you have a compression device. So you attach the compression device. Over 2 planes you can do it. In a single plane you do it, in 3 planes you do it, it becomes difficult. Where you try to correct a midfoot and hindfoot charcot. Do it in 2 planes, it's able to do it.
And restoration of foot height, was that a problem in your cases, sir?
Restoration of foot length.
Height, sir.
Height, no. There's no problem.
I don't have I don't have an orthopedic surgeon like Rajesh has. I don't have that luxury of having an orthopedic surgeon. In a chronic burnt out charcot with a midfoot ulcer, probably can I just get away with an exhaustectomy, which I think I can do myself? When would you really want to go for this advanced reconstruction?
Exhaustectomy is still the option.
When do you want to combine it with?
If there is complete collapse, if there's complete collapse, your exhaustectomy cannot be done, like what Dr. Aparajita showed us. So it's been continuous. People been continuously doing exhaustectomy, no response. When the foot is completely unstable, then you'll have to fix it. There's no option.
Thank you, Dr. Aravind, for that wonderful presentation on the surgical management of the charcot.
Thank you.